So thanks everyone for coming, the people who have made it so far, and I'm sure there will be people who keep joining us. We're here for the Abortion Care in General Practice Provision and Referral webinar. Before we begin, I'd like to have our acknowledgement of country. So I would like to acknowledge the traditional owners of the land on which we're meeting tonight, the Ngunnawal and Ngambri peoples, and I wish to acknowledge and pay my respects to their elders, past, present and future, and acknowledge their continuing culture and contribution they make to the life of this city and the region, and acknowledge and welcome any Aboriginal and Torres Strait Islander people who might be attending today. So I'm Dr. Melanie Dorrington. I'm a Canberra GP working down at Interchange Health Co-Op and also at the moment at Women's Health Service. And I'm a medical termination prescriber. That's who I am. And tonight's event wouldn't be happening without the support from CHN, which we appreciate, and my co-presenters, Dr. Jess Titterman and Dr. Martina Mende, who I'll introduce when we get to their sessions. So for housekeeping, all participants are muted at the moment. If you have any questions, please put them into the all panelists in the side panel of your Zoom window, and we will aim to answer any questions in the Q&A session at the end. And this is also being recorded and will be made available to GPs via the CHN website. We have not put in a thing for RACGP points, but you can put this in for your self-learning if you want to submit it yourself via the RACGP website. And so I sort of introduced our panel before. I'll introduce us all now. So myself, I sort of gave a brief introduction to. I've got a strong interest in women's health and sexual and reproductive health, and I've been providing early medical abortion for 3 years. Dr. Jess Titterman is a GP at the Women's Health Service. She has a strong interest in reproductive health care and has been providing early medical abortion since 2019 and was one of several people involved in advocating for medical abortion prescribing in general practice in the ACT. She also works at the Therapeutic Goods Administration. And we have Dr. Martina Mende with us as well, who's a GP obstetrician at Queanbeyan Hospital, a medical educator at Sexual Health and Family Planning ACT, and an abortion care provider at Murray Stopes International. So I'm going to hope that most people are with us now, and I'm going to flip over to start my own presentation. I'll jump into that now. Okay, so as I stated earlier, I acknowledge that we're meeting on Aboriginal land, and I'm presenting from the unceded land of the Ngunnawal and Ngambri people. Before I start, I just want to point out that we're going to be taking a person-centered approach to discussing abortion. We're not going to be getting into the existential question of when life begins. In my presentation, I'm generally going to be referring to pregnant people rather than women, as per the WHO guidelines on abortion care. As providers of sexual and reproductive health services, including abortion care, we must consider the needs of and provide equal care to all individuals and recognise that cisgendered women, transgender men, and non-binary, gender fluid and intersex individuals with a female reproductive system are capable of becoming pregnant and may require abortion care. So if you feel comfortable, I'd like you to, and most people aren't being seen at the moment, so hopefully you are, can you please close your eyes or find something to look at and just reflect on what your life goals are? What are you planning to achieve in life? Specifically, what do you see yourself doing over the next 3 months or 12 months or 5 years? Education, travel, career, relationships, family, where are you going to live? How are you going to spend your time? Now we are going to disregard gender, sexuality, age, and reproductive capability for everyone. No matter who you are, you find out that you're pregnant. What are you going to have to change to those plans? What sort of implications would it have to be pregnant? An unplanned pregnancy pretty much always means a change in plans, but we all have different capacity to facilitate these changes. There are short-term and long-term changes. And there are potentially major implications on where we end up in life, especially if we're starting out for a place where we're struggling at this sort of important juncture of an unplanned pregnancy or unintended. Could you manage with persistent nausea and vomiting or significant fatigue for the next 3 months or so? What about if you found out you were 5 months pregnant? Think about the last few weeks or months of your life. How healthy have you been? Are you exercising and having a good diet? Are you drinking alcohol, smoking, using recreational drugs or prescribed medications? So before we go on, just think for a moment how that makes you feel about life. Do you feel in control and secure? Or does even contemplating making such a change emotionally drain you? So what will be your social, emotional, relational and financial costs of an unintended pregnancy? So in the USA, most people seeking abortion are between the ages of 15 and 30 years, and most are living below the poverty line. As per the recent published report that came from Organon on the impact of unintended pregnancy, which was prepared by HT analysts. This was just published in June this year. We can see that the number of unintended pregnancies and the outcome of these pregnancies is quite large, with an estimated 40% of pregnancies in Australia being unintended. Consider the costs of these unintended pregnancies, which affect the pregnant people and the community, whatever the outcome of the pregnancy. So as the report states, an unintended pregnancy has significant economic impacts both on women and the broader society. In Australia, the total cost of unintended pregnancy was estimated to be 7.2 billion in 2020. Over half of these costs are borne by the pregnant person. However, impacts go beyond economic costs, with long-lasting effects on physical, emotional, and social well-being of the pregnant person and infants, and profound societal impacts. We are here because we're health professionals. We know that while pregnancy can be natural, it also evokes a lot of physiological changes in the body, and it's not without its risks. So in the USA, you're 14 times more likely to die from carrying a pregnancy to term than from having an abortion. In Australia, an observational study that Marie Stopes International did of over 15,000 pregnant patients accessing early medical abortion from March 2013 to September 2015, so 2.5 years, demonstrated 1 death, which was actually from necrotizing pneumonia, and an association between that and the early medical abortion has not been established. While pregnancy and birth-related death may be relatively rare, there are severe morbidities. 1 in 4 births in the USA is associated with a serious complication, including trauma and laceration, infection, hemorrhage, gestational diabetes, severe preeclampsia, and eclampsia. The list of medical conditions made worse by pregnancy fills textbooks. Pregnancy is risky. So later on, I'm going to refer to a US study called the Turnaway study. But 1 in 20 women in the Turnaway study sought abortion because they did not feel healthy enough to continue with pregnancy and give birth. Complication rates for abortion are about 2% in the USA. For wisdom teeth extraction, it's 7%, 8 to 9% for tonsillectomy, and 29% for childbirth. The risk of a major complication from abortion is less than 0.25%, and risks with abortion do increase as gestation increases. So we need to recognize that accessing abortion is a human right. I know this is a busy slide, but these are quotes from the WHO Abortion Guidelines 2022. You can take a screenshot or you can read the whole guideline yourself. The Public Health Association of Australia abortion policy states that termination of pregnancy should be regarded in the same way as other medical procedures and should be included in health service planning. We need to ensure that we're supporting our patients in access to the health services that they seek. They have a human right to access abortions, and preventable maternal deaths are a violation to the right to life. Ensuring access to services in accordance with human rights standards is part of our duties as United Nations members, to eliminate discrimination against women and to ensure women's right to health and other fundamental human rights. At the same time, we need to ensure that appropriate access to information and education around contraception and family planning, as well as access to these services, is provided, with a goal of reducing the incidence of unplanned pregnancy and of abortion. And in Australia, we currently have no federal level data, and we don't have any data from the ACT on abortion. So at this point, I want to acknowledge that stigma that is felt around abortion is not only felt by those seeking abortion, but also by those providing abortion. And as such, I also want to specifically thank Jess and Martina coming on here tonight, as well as providers of abortion, and other people who make it known that they do provide abortion. To ensure both access to abortion and achievement of universal healthcare, abortion must be centred within primary healthcare, which then needs to also be fully integrated within the health system. And we must be able to facilitate referral pathways for higher level care when they're needed. Quality primary healthcare is evidence-informed, community-delivered, and person-centred. Making abortion available and accessible within primary healthcare is a safe and effective strategy to advance equitable access to and provide an enabling environment for abortion. Now we're going to go back to the question of why do people seek abortion? A very simplistic answer could be because a man ejaculated. The Turnaway study is a pivotal prospective longitudinal study that was conducted in the US, examining the effects of unintended pregnancy on women's lives. The main finding is that receiving an abortion does not harm the health and well-being of women, whilst carrying an unintended pregnancy to term can have lasting financial health and family outcomes. Over a contraceptive lifetime, a sexually active woman could fall pregnant twice on the pill, 4 times with condoms, and 7 times using withdrawal. The actual likelihood of pregnancy, if you're having sex and you don't know your cycle, is 3% per episode of sexual intercourse. In the 6 days leading up to ovulation, it's 10% and 0% for the rest of the cycle, so your usual 22 days. Not using contraception is not a version of Russian roulette. It's more like crossing the street against the green walk light, not putting on your seatbelt to move your car a short distance, or using the 5-second rule to eat the biscuit you dropped on the floor. In the Turnaway study, 2 women died from childbirth-related causes. No one died who actually received the abortion that they sought. In terms of women who actually had to have their pregnancy because they were turned away from abortion, they had complications from delivery, chronic head and joint pains, and experienced anxiety. Importantly, not being able to access a sought-after abortion increases the risk of living with family and domestic violence. Once you have a baby with someone, you're tethered to them for life, even if you leave. Abuse continues once relationships end. You can't actually get away from that person, and generally you're aware that they will hurt, whether it's emotionally, psychologically, or physically, your child, their child. Women who were denied abortions experienced economic hardships not experienced by women who received their wanted abortions. When asked about why they wanted an abortion, women gave specific and personal reasons. Their fears were borne out in the experience of those who had to carry their unwanted pregnancies to term. These were around poverty, relationships dissolving, which they did whether or not a pregnancy was continued, and children being worse off for their health and development. Access is really important. Dates for medical termination are restricted. Costs for surgical termination can be more expensive. But if someone doesn't have a Medicare card, the costs of a surgical can be much better. Why don't GPs advertise? We raised stigma earlier. There is still hesitancy from GPs to clearly state on their practice website that they, or a specific GP in their practice, offered termination of pregnancy due to concerns regarding backlash and abuse. And if that's how we feel as medical professionals, how do our patients feel? Is there something stopping you from doing the 4-hour training to be a termination provider? So technically, access in the ACT should be broadly available. And I acknowledge the work that's currently being done by ACT Health or the ACT government to make abortion freely available to everyone up to 16 weeks, with some caveats around who can actually access in our private facilities. But currently, there are big differences in costs and in travel required. And options can be impacted on by timing, including whether or not you can find information and referrals in an appropriate time frame. But there can also be delays in knowing about a pregnancy if someone has irregular cycles, if they're using contraception, if they're stressed and so they're not noticing that they've missed a period or expecting that a missed period is due to stress. Denial, obviously, sometimes a reason for not realizing. Sometimes people are too young to actually consider that pregnancy has happened to them. It's not within their expectations. Or there might be delays seeking abortion because of being unaware of limitations that do exist, or barriers related to language, transport, finance, reproductive coercion, domestic violence, childcare, having to have a support person available. As primary healthcare professionals, consider when you see someone with an unintended pregnancy, whether they have made a decision or not. If they haven't, either you can offer them non-directive counselling. If you've done your training, you can do the item 4001, or you can refer them. There are a couple of options, including at ShiftPact. If they have decided that they want an abortion, we hope that after the next 2 presentations, you're going to feel comfortable talking to them about their options and supporting them access whatever option they choose. I've just got a couple of resources up there that I think are important. And I'd like to acknowledge that there are very few translated resources for people who don't have English as a first language. Okay, I'm going to stop sharing now. Jess, are you happy to take us through early medical abortion, please?
Yes, can do. And also, I just wanted to acknowledge that, unlike advertised, I am not Dr. Gillian O'Reilly, but I did want to assure you that in keeping with Canberra being a very small town, that Gillian and I actually have a lot in common. Obviously, we both have dark brown hair. We're both doctors and medical abortion providers. We went to the same schools and same medical school, and went together to the health minister at the time, and also a local Greens MLA advocate about having prescribing of medical abortion in general practice. So we definitely, Gillian and I have a lot in common, so I was pleased to be able to step in tonight. So as Mel said, I'm going to be talking about early medical abortion or medical termination of pregnancy. And one thing that I've been sharing since I learnt it at, I went to the Australasian Sexual Health and Reproductive Day recently that put on by ASHM, and there was interesting discussion around terminology. I have tended to say termination of pregnancy. There was a lot of people, I think, in an effort to reduce stigma and saying abortion is preferred language, and I believe children by choice use abortion. And it was interesting. I quite find the linguistic aspects interesting, and someone made the point that you can terminate a lot of things, and all pregnancies terminate, just sometimes in a live birth, sometimes a miscarriage, sometimes an abortion. So actually it's not very specific. So anyway, that was my takeaway. So key things: medical abortion won't be an appropriate option for all patients, but in terms of identifying who it may be an option for, probably the key point is that it can be used up to 63 days or 9 weeks gestation. After that point, the surgical options. Of course, important to make sure that you've got a patient who's making a voluntary informed choice without contraindications. And I left the note in there about the legal requirements, and they do vary by state and territory, but we're certainly getting there in Australia with removing some of those barriers. There are a number of contraindications. Many of them are not absolute. Of course, if someone has a history of anaphylaxis to misoprostol, this is not the option for them. But for example, an IUD in situ, you can remove the IUD and proceed. So some are absolute and some are more relative. Ectopic pregnancy is an absolute no-no, and you really want these people to have access to emergency care. So important considerations if you've got patients who live rurally particularly. Some cautions and down the bottom there, and that's largely because people with these comorbidities and also heavy smokers over the age of 35 were not included in trials. So it's not necessarily that these would definitely present a problem. It's just that it's unclear. So it's a less known space. And severe anemia is an issue, noting, and we'll get to it, but bleeding considerations. So what is it? And in Australia, it's MS2-step, the combination mifepristone and misoprostol is what's used for medical abortion. So the two drugs in combination have actually been used for this purpose for many years in other countries, but mifepristone wasn't registered in Australia until 2012 and was first PBS listed in 2015. So it's relatively recent that this has been an option in Australia. The way that the two drugs work is, as the name tells you, and I say this to my patients, MS two-step, it's 2 steps. So the first step is the mifepristone, which they take orally. It's a synthetic steroid and basically competes with at progesterone receptors, which you get then the following effects of stopping pregnancy growth, sac detaches, can soften and dilate the cervix and increase or prepare the uterus for contractility, which is where the misoprostol comes in. Most people don't get any noticeable effect, not like that they themselves consciously experience after the mifepristone. Some people do get some cramping and bleeding after that first step, but a lot do not until after the second step, which is the misoprostol. It's recommended specifically to take it buccally, so absorbing it through the mucosa of the mouth, and this is taken 36 to 48 hours later, and that is to allow that time for the mifepristone to take effect. And the misoprostol then directly induces uterine contractions and relax the cervix so that the pregnancy is passed. You'll see variable quotes about how effective it is, 93 to 98%, or failure rates of 2 to 7%. So it's comparable, and Martina will talk more about surgical abortion, but it certainly is generally very effective. So in terms of prescribing, as Mel has already touched on, there is a sort of training and registration requirement for people prescribing medical abortion. It is TGA registered, the MS two-step product for this specific purpose, up to that 63 days gestation. It is also PBS listed, so it is subsidised for people with Medicare access. Meaning that for healthcare card holders, it can be a very cost-effective option. The prescribing program, they quote 3 to 4 hours. It probably depends on, some people move through it more quickly, and then you do an update or a refresher every 3 years. And I think it's a good program. They also, as a prescriber, we have access to online resources, patient booklet, a full manual, with a lot of information, all the evidence from trials. So I think I certainly, as a prescriber, feel like there's a lot of information through MS Health that is available. There's no, legal or specific prescribing restrictions for GPs in the ACT. There used to be, and I noted that when Mel said she's been prescribing for 3 years, and I've been prescribing since 2019, which is also nearly 3.5 years, because that's when the legislative change happened in the ACT. Prior to that, the prescribing of all, abortion was limited by geographic location to be Murray Stopes International and the Canberra Hospital. So that allowed this to be prescribed in general practice. Dispensing pharmacists also need to be registered. Their sort of training or registration process isn't as onerous as prescribers, and I certainly Mel and I and other local prescribers have worked with many pharmacists to sort of reach out and encourage them to become registered, so that we have more options for where we can send our patients. In terms of what patients can expect, cramping, pain and bleeding, like with a miscarriage, are expected, variable in severity, and I find doesn't necessarily correlate to gestation either. I often, what I most often have from patients reporting is that actually the bleeding and the pain wasn't as bad as they expected. But anecdotal, onset of symptoms is usually within 4 hours, can be a lot quicker, and it can take a lot longer. But people are asked to follow up if they've had no symptoms after 24 hours, by which point you'd expect things to be happening. Common side effects of misoprostol, gastrointestinal effects, but they tend to be limited and certainly shouldn't last more than 24 hours. Given that we're talking about uterine cramping, a non-steroidal anti-inflammatory is generally the most effective pain relief, and a lot of us recommend that they take it sort of before the misoprostol, the second step, or sort of at the same time, so that they've got that effect when the pain starts. And a lot of us prescribers also give them a small supply of stronger opioid analgesia and an antiemetic, because if you've got horrible cramping pain and you're bleeding heavily and you're vomiting, it can be pretty unpleasant. And so making sure that people have access to these sort of step-up options can be very helpful to support them going through this at home and try and help them not need to seek additional care. It is recommended, for the reasons I've just talked about, that people, I strongly counsel my patients to have a support person with them, so that I think often in the event that their pain was too severe, the bleeding was too heavy, if they need to go to the emergency department, if they need someone to go and get something from the chemist, I recommend people don't do it alone. Benefits over a surgical abortion is avoiding an anaesthetic or a sedation. They can do it at home, which for a lot of people is a big plus, but needs to be balanced. You know, it needs patient choice. Many people don't preference a medical abortion. And I think this is where counselling about what they can expect is really important. And noting that you know, you can't predict what level of pain and bleeding someone will experience. Risks include failure, it doesn't work, and you've got an ongoing pregnancy. As I said, that's sort of quoted as variable. Sometimes if it's not effective, you can do a second lot of MS2 step, or as we've discussed, refer for surgical abortion. Heavy or prolonged bleeding is probably the risk I counsel people about most, and it's sort of the most acute risk, is you don't want someone staying at home with bleeding that's too heavy for too long. But it is not common. Most of the time it is, and it's quite time limited. So I explain to people that the pain and the bleeding is at its worst until the pregnancy passes, which is maybe a few hours, and then tends to taper off quite quickly. Infection is rare, but can happen. And certainly if people, I mentioned fever, chills, those sorts of things from the misoprostol, but if people have those symptoms that are persisting after 24 hours, I'd be suspicious that they're unwell. Retained products, again, so history, that follow-up's important there. There's a 24-hour hotline run by MS Health, who are the sponsor of MS2 Step, which is great. I say to people it's a really good first step if they are concerned. And as I said there, a good rule, if, you know, 2 or more proper pads, not panty liners, an hour for 2 hours is too much, or if they're concerned, not managing pain, off to ED. Follow-up is recommended to be done at 14 to 21 days. I aim to see people at 2 weeks, unless there's some issue with the timing, and that's from when they take the mifepristone. Assessing what symptoms they experienced after they took the medications, because you're expecting that, yes, I had cramping pain, bleeding, passes, and then it settled down and I'm feeling okay. Wanting to assess for ongoing pain, as I said, any signs of infection. They may still have light bleeding or spotting at this point, but you'd be concerned for infection, endometritis, or retained products, or incomplete abortion if they had more significant symptoms. A lot of people use a serum beta HCG measured at baseline and then at follow-up, because that significant drop can indicate success. But I certainly wouldn't rely on that if I had a history that suggested that things hadn't gone as they should. And it's worth noting, and Martina might be able to speak to this, I think Murray Stopes use a sensitivity urine beta HCG a little bit later, but noting that it can be positive for some time. So there's no one way to do follow-up. I think it's considering all of these things together, and history, as is so often the case, is probably the most important. Of course, the follow-up ultrasound, if you have concerns about failure or retained products, can be useful. So importantly for you, and I'm not hurrying myself along, I think I'm pretty much done, is if referring to a medical abortion prescriber, things to consider: needs to be under 9 weeks, can be right up to that. I definitely see people at 8+, but not over that. Otherwise, they need surgical referral options. Ultrasound isn't mandatory; it's not required by the registered indication, but it is recommended. And most of us, I would say locally, like to have an ultrasound. Confirming the gestation in many people can be, is important. So a lot of people, as Mel said, have no idea, their cycles are regular, or they have no idea when their last period was. We need to make sure we're in that under 63 days window. But also, I really like to make sure that we've got an intrauterine pregnancy, because not wanting to give someone MS2 step with an ectopic pregnancy. And I mentioned beta HCG is useful if you refer, but it's not essential. And particularly, if someone has had a beta HCG a week ago from when they're actually going to be taking the mifepristone, I repeat it, so it's not always needed. Blood group is not required, because we don't give anti-D, and so that's something we can cross off. And it certainly just worth noting that this can be, like so many opportunities, a good time to discuss STI testing, and discuss contraception. So talking about follow-up contraception is an essential part of these consults. And so just how do you find a provider? So there's a really good termination of pregnancy section on health pathways. And if you look in there, there's a lot of prescribers listed and dispensing pharmacies. And there's not all of us are on there. There's quite a few people who do prescribe but aren't on health pathways. And so sexual health and family planning actually probably have a bigger or more comprehensive list. But the other thing is, well, I'd always be happy for people to reach out to me if they're not sure where to send someone. We've got a pretty good little local network, so can usually try and work out who might be able to see someone and when. Thanks.
I think that was all nice and clear. Martina, are you ready to take us through surgical, please?
Okay.
Perfect.
Now, I apologise. I can't see all the participants, so I have no idea how many people we have on and who we have on. So thank you very much, everyone, for giving up your time tonight to have some education around termination of pregnancy or abortion, particularly in Canberra. So before I start my talk, and I'm really conscious of time, I just wanted to add, in terms of prescribing MS2 step, the recent MPS data shows that there's only 2,850 GPs out of 41,000 GPs in Australia registered to prescribe MS2 step. So we're really keen to increase the network in Canberra. So just briefly to introduce myself, I'm Martina. I'm the clinical lead for the maternity unit at Queanbeyan Hospital, and I'm a GP obstetrician. I also work for Murray Stopes Australia, and I'm the primary abortion provider in the ACT. And our patient catchment area really is everywhere out to Western New South Wales, the Victorian border, the South Coast, the Southern Highlands, and the Goulburn region, particularly for surgical termination of pregnancy. And I'm also an educator for sexual health and family planning and work at ShiftBack. And I'd also just like to acknowledge Dr. Jenny Leong for her, because I've adapted some of her slides and also some slides from a talk that I do there. Okay. So, sorry. First of all, I just wanted to quickly let everyone know that there's a number of networks that can provide support for GPs providing abortion care. So AusCAPS is a funded sort of network of clinicians, and it has a lot of good information on medical termination of pregnancy, as well as a lot of information on contraception and IUD troubleshooting. There's some really experienced sexual health and family planning doctors that participate in this site. And so if you join and you answer questions, you can get some really good answers. There's also a website called MTOPS Down Under on Facebook. I'm not on Facebook personally, but this is a secure Facebook site, and you actually need to provide your APRA registration to be part of the group. So it's quite a safe area. And also, if anyone's interested in our local WhatsApp group, I think Melanie holds the key to the WhatsApp group. But if you are a prescriber and would like to join a network just for information, then we often are a little bit of a brains trust and can help people out with questions. So I'm just going to run through a little bit of a case. Oh, sorry. And I know everyone's probably dying to get on with their evening, so I won't take too long. So we've got Sarah. She's a 25-year-old G1P0 who presents as she's just found out she's pregnant. She took the emergency contraception within 72 hours. She's well, no allergies, no medications, and she's a new patient. So the first thing I just briefly wanted to talk about was what's actually our role for Sarah. So our role as GPs, we wear many hats. We need to work in a framework, and the framework that we need to be thinking about with all people who are pregnant is that we need to think about reproductive autonomy. We need to remember that the woman is the expert in her own life, and I've stolen a few of Mel's little quotes there, meaning that we need patient-centered care. We also need to think about trauma-informed care. So we need a safe physical and emotional space for people to see us. We need to be non-judgmental in our care, regardless of your values, and we need to be aware of reproductive coercion. I could do a whole talk on all of this, but I just want to sort of put that into this framework. Our role is to do a clinical assessment. We need to think about information provision, and hopefully tonight we'll just aid you all with a little bit of information provision. We can think about non-directive counselling, and that might be something that we're comfortable doing, or it might be something or a place that we need to refer to. And then we need to think about either providing an abortion or a referral for an abortion if that's the direction that the woman wants to go. Clinical assessment, we need to just, and we've sort of been through this already, but importance of accurately establishing a gestation. We need an accurate menstrual history. We need to know about sexual activity, and we need to know about signs and symptoms of pregnancy. You can consider an ultrasound for gestation and obviously to exclude an ectopic. Now, places like MSA and Gynecology Clinics Australia will do an ultrasound on the day. But certainly for women that are travelling long distances, I find it really useful to have an ultrasound before they present so that we can actually plan their abortion care. A baseline quantitative beta-HCG. I should also add there a blood group if they're considering a surgical termination of pregnancy. And it's also an opportunity to talk about STI screening, CST screening, and to begin the conversation about contraception. Some women at this stage may not be ready to talk about contraception, but also as an abortion provider, I find it really helpful when there has been a discussion so that when they come to see me, we can have a more in-depth discussion and sometimes make decisions on the day of termination of pregnancy. I just wanted to remind everyone about the limits of quantitative beta-HCG. Not infrequently, I see a woman who's had a blood test and the blood test indicates that she's 6 weeks. And when I pop her up onto the bed to the ultrasound, as soon as I look at her tummy, I realise she's probably about 26 or 28 weeks pregnant. So just being really aware that a blood test is not the only way to diagnose a pregnancy. And I think that we had more issues during COVID when people were doing telehealth consults. But I just would always encourage you, if you see a patient face-to-face and you have any inkling that they could be further along, to do an examination just to make sure. So Sarah comes back, it's the second consult, and we've organised some investigations for her. We've got an ultrasound with an intrauterine pregnancy at 5+3, and there's a yolk sac present confirming an intrauterine pregnancy. Baseline beta HCG is 7,900. She's Rh negative. Her STI screen is negative, and her CST is due. She is sure she does not want to continue the pregnancy, but is unsure if she wants an MTOP or a stop. So, I'm just going to move my camera. So this is just a little comparison, which I find quite helpful. And I think this is really helpful for people that are maybe providing information for women who are making a decision. So you can see that there's a difference in completion rate between medical and surgical. One of the biggest questions is, of course, gestation. So are they eligible for a medical termination of pregnancy? And also access. So medical termination of pregnancy, there is generally more access. There's telehealth, there's general practitioners that prescribe, and there's also specific providers. And it's also something that you can complete in your own home. As you've heard before, I see women for surgical termination from Western New South Wales and all throughout Southern New South Wales as well. So access can be a real issue for these women. There's no, with a medical, there's no surgery or anaesthetic complications, whereas obviously with a surgical, there can be a risk of surgical anaesthetic complications. Medical, you have prolonged, it's over 48 hours, and then you can have some prolonged bleeding post, and you also have a need for follow-up. Surgical is a day surgery procedure. There's a heavier perceived bleeding and potentially more pain and cramping with a medical as opposed to a surgical. Medical can be more private, and a surgical does require a support person. So the person needs to have someone to drive them home after an anaesthetic. That's really important. And there is a difference in cost. So what are the side effects of a surgical abortion? So pain and cramping, it's usually managed with paracetamol and NSAIDs. Bleeding is usually light to moderate. We do give anti-D to all women having a surgical termination of pregnancy, regardless of gestation. And I always warn women, and this is for both medical and surgical, about the day 2 mood drop. So as the pregnancy hormone decreases, they can experience almost mood changes that are equivalent to the baby blues. Obviously, really careful how you phrase that, but it's really important to warn women about that because it can really catch some women and really create some conflict in their sort of confidence in their decision. If you explain that it's really normal to feel like that a couple of days after an abortion, then that actually kind of eases that path for them. So in terms of risk comparison, I think this is really important because obviously patients want to know about what is the risk. So we've talked about completion rates. So the completion rate is higher for a surgical termination of pregnancy, and the ongoing pregnancy rate in medical abortion is slightly higher. Retained tissue appears to be slightly higher in medical abortion versus surgical abortion. Transfusion rates are around the same. Infection rates also around the same. And obviously the biggest risk is the risk of surgical complications, particularly uterine perforation. Uncommon risks of stop include sepsis, anemia, DVT or PE, cervical stenosis, anaesthetic complications, injury to the cervix or the uterus. Perforation is about 1 in 1,000, and Asherman syndrome. So obviously we break stops into different gestations, and currently in the ACT, stops are available at MSI up to 14 weeks, and we will consider up to 16 weeks with appropriate triaging. I'll just make a small correction to Mel's first slide. So Sydney MSA now only does up to 19.6, as does Melbourne. So later termination of pregnancy is becoming harder and harder to access in Australia because a lot of the clinicians that used to provide the service are actually retiring, and there's not a lot of new people training in that area. So this has become a really difficult area for women. And I do probably once or twice a year have a woman who has a really good reason for a termination of pregnancy who is over 20 weeks pregnant. So we can do a dilation and suction curettage. We can also do a manual vacuum aspiration, which uses a softer, more flexible tube. Most will be offered under some sort of sedation, but we can do termination of pregnancy or surgical terminations under a local anaesthetic. And some facilities will offer a general anaesthetic. Really importantly, contraception at time of a stop, the pill Implanon, IUD depot, don't delay. A lot of patients are getting the message that they shouldn't do contraception at the time because of bleeding, you know, if they have bleeding issues afterwards. There's very little evidence that there's any increased risk of bleeding complications from the contraception. And I'd really encourage patients that as they're there to consider contraception at the time of termination of pregnancy. So surgical terminations above 16 weeks are getting more complicated. Maternal mortality increases, so less than 1 in 100,000 prior to 14 weeks, rising to 12 in 100,000 at greater than 21 weeks. So the earlier we can see people, the better. Greater than 16 weeks, it's a multi-day procedure. There's pre-treatment of the cervix with dilators, and dilation and evacuation is by forceps. So it's a much more involved and skilled procedure. Really importantly, you can do a stop for any woman, but it needs to be the safest way and in the safest facility. So when you are considering referring for a surgical termination of pregnancy, we need to think about anaesthetic risk, BMI, complex uterine abnormalities, and complex medical issues. And this comes down to some of the barriers. So the day surgeries that currently provide medical termination are limited because we are day surgeries. So some of the biggest barriers to surgical termination are actually gestation, cost, need for a support person, and the contraindications in smaller facilities. So in terms of referral pathways, and I just really want to allow some time for questions at the end. So in terms of referral pathways, most women will actually self-refer and won't see a general practitioner prior to a referral for a termination of pregnancy. Some women will see a general practitioner for some of the initial investigations. And we really do encourage women who have a good relationship with their GP, who maybe aren't ready to discuss contraception, to go back and see their general practitioner as soon as possible. Just another note on contraception: if you know a woman has had a termination of pregnancy and presents within the 3 weeks post, her pregnancy test will still be positive, but you definitely can do any form of contraception except an IUD at that stage. So that's really important. IUDs can be inserted post MTOP at around 3 weeks once you have a negative pregnancy test and the bleeding has stopped, and also post-surgical termination as well. So just we often have a few issues with implanons and positive pregnancy tests post-surgical and medical termination of pregnancy. So I've just popped the number for SMA and Gynecology Australia. So Gynecology Australia is a clinic in Queanbeyan. They both offer online booking and a phone number to call. They both do an ultrasound on the day. Limit of MSA in Canberra is 14 weeks, but look, I am able to do up to 16 weeks, but we need to appropriately triage the patient prior. We do have a BMI limit. It's around 42. It is a little bit flexible, and it does depend on patient assessment and their anaesthetic risk. And we do IV and local insertions of IUDs. GCA has a weight limit of 120 kilos. They also do IV contraception, so anyone wanting an IUD under sedation. They don't do MTOPs. And TCH does have a doctor who will now perform public termination of pregnancies, but it is really for the complex cases, as they can't manage all the TOPs that need to be done in the area. So they will do a stop up to 18 weeks. After 18 weeks, it is still an induction of labour. So the woman will have to deliver vaginally after an 18-week cutoff. And this can obviously be really complex and traumatic for a woman experiencing this. So the TCH cases that we will often refer are people with complex medical issues, women with high BMIs that are not safe for our anaesthetic, or have other complex histories that we don't deem safe to perform the termination in the day surgeries. Okay, and I just wanted to talk about a couple of myths that sometimes come up with my patients, and also myths that I hear coming out of the community and obviously Dr. Google. So just really briefly, there's no link with abortion and breast cancer. That's a really old myth. Mental health, Mel's spoken a lot about that. So we know that actually women that are denied abortion actually have worse mental health outcomes. There is a saying, short-term grief, long-term relief, but women who do more poorly post-abortion are women that have certain personality traits, later gestation, medical or genetic reasons for an abortion, prior psychiatric disorders, conflict with cultural or religious beliefs, or obviously reproductive coercion. and also if there's a great stigma around abortion within a woman's social and cultural environment, which is unfortunately still Australia. Really importantly, abortion is safe for future fertility. In countries where abortion is legally available, women who have a single uncomplicated termination of pregnancy are not at risk of infertility from the procedure. If there's short pregnancy to pregnancy intervals, as with any pregnancy, there is a higher risk of miscarriage. And there is some weak evidence that if you have repeated surgical procedures, which do include stops, that there is a slightly higher risk of cervical incompetence or preterm birth. So I just wanted to quickly mention those because they're common myths and common questions that we see through the clinic. So any questions?
It looks like Kirsty's asked us a question about comparing the costs in the ACT of medical and surgical termination.
Yeah, so it really depends. Hi, Kirsty, how are you? So I'll just briefly speak to that because obviously general practitioners will charge different fees for medical terminations, and I think that's GP dependent. I believe a lot of the GPs will actually bulk bill in cases of financial hardship or other cases. In terms of the cost is fairly similar. And sorry, I don't have the cost off the top of my head, but if you have a Medicare card, I think it's about $100 difference with the stop being slightly more expensive. For Medicare card holders, if they have private health insurance, often a stop is more cost efficient because the private health insurance will actually pay for the surgical termination of pregnancy, but won't pay for a medical termination of pregnancy. But if you'd like specific costs, I can get those for you. I just can't remember off the top of my head. Medical under 14 weeks is around, a surgical under 14 weeks is around $650 if you're a Medicare non-healthcare card holder. And I think a medical's around $540 from memory. If you're above 14 weeks, it becomes significantly more expensive. And if you're above 16 weeks and up to 20 weeks, it can be around $7,000, which is really prohibitive.
And it's the travel to Sydney for those ones too.
Yeah.
Which, and as you say, multi-day procedure. So you're talking hospital admission, anaesthetic, like there's all the associated
what
costs.
do you do with your other children? What do you do with work, etc.? Yeah.
And I think the other thing there is for non-Medicare card holders, for the actual MS2 step script, it's over $350, about $383 for the actual just your MS2 step, and that's blood tests and most likely ultrasound as well that we're needing to do and things. And so that's why we say if someone doesn't have Medicare. Oh, and it looks like Marissa's just asked that question. So I believe that students when they come here are meant to have a certain type of insurance.
Doesn't make a difference.
Oh, okay. They
don't, and the cost is still really prohibitive for medical. So essentially, that insurance doesn't cover. Oh,
not medical, but for
the surgical.
Yeah, so private health insurance. Most private health insurance providers actually will cover surgical termination of pregnancy as long as you've got at least kind of bronze to silver or low to mid cover. You don't have to have obstetric cover for it to be for a surgical termination of pregnancy. It falls under gynecology. So most international students will and should have that. Oh, thanks, Claire. Gosh, that's terribly helpful. You've just put all the information up there. Thank you.
And certainly, Marissa, we're getting quite a few international students coming through for a bit to Women's Health Service, but because without Medicare, certainly the cost of a medical board is quite high. And for the reasons Martina just explained, we generally, in terms of cost, recommend surgical because it will be often covered by their insurance.
Yeah.
So,
and I would also add too, if you do an IUD or an implant at the time of a surgical termination of pregnancy, you just need to pay for the device. So it's also, in terms of someone who's really struggling financially, it's a fairly cost-effective way to do it, as opposed to having to come back and pay for another consult later on to have the insertion.
Yeah, it's a good. I was going to make that point on following on from what Martina said, that certainly I I'd often try for my patients that are considering an IUD or an implant for us to plan to do that at follow-up. So sort of rather than seeing them at 2 weeks, plan to see them at 3 weeks and do get that lark in at that time. But I would say that I don't have as much success getting people to commit to contraception as I would like. And I think that's a fairly common experience for those of us working in this space, as Martina said. Sometimes people aren't ready to consider it, or that made us, or so I think it's, and again, certainly if people are engaged with an ongoing GP, I try and encourage that conversation. But I think that's somewhere where really patient autonomy is in tension with a desire to prevent further unwanted or unintended pregnancies.
And I would say some of the studies that MSA have done, one of the about what women want in abortion care is actually a lot of women feel coerced or pressured into contraception. So I always ask permission whether I can talk about contraception with the woman, and I always ask permission to give information about contraception, because that came out really strongly in some of the studies. It's complicated because sometimes it can perceive as judgmental talking about contraception, because women are highly stressed, or people who are pregnant are highly stressed. But look, other women are really keen to have the contraception sorted out on the day so they don't need to come back, particularly if they've got work, study, family commitments, etc.
Yeah, it's a good point. Not making them feel like the access to an abortion is conditional on committing to contraception. It's ultimately their body, their choice.
And I'll just clarify, there's a question in the Q&A, and it says that one presenter said not needed, anti-D is not needed, and the next presenter said anti-D to all patients. So I'll just clarify, anti-D is not needed for all medical termination of pregnancies. Anti-D, who are Rh negative. Anti-D is needed for all surgical termination of pregnancies who are Rhd negative. So not in MTOP, yes for stop.
And I was going to say, in terms of contraception, we have the option of putting in an implant on at the time of doing, like, prescribing the MS2 step. We can do it from that early because it's not going to impact on it. And I think that can be important as an option, depending on, because someone can fall pregnant again as easily as 2 weeks afterwards, or it's whenever their cycle comes back, but it's still within 2 weeks afterwards. So it's not like you've bought yourself a couple of months.
And also, don't delay starting the pill until the first period. Start the pill at the time of the termination of pregnancy. I see a lot of terminations and then repeat after a month coming back because they've got an early pregnancy again, unfortunately.
I was about to say the same. That I think that waiting, and as you say, a lot of people thinking that they need to, or there being this reluctance, and
one thing that I thought of, if just whilst hopefully a few more people think of questions, we've got a little bit more time, was in terms of antenatal bloods. And I certainly see people come through to me where the GP has ordered the entire set of antenatal bloods when the patient informs me that they were never intending to continue the pregnancy. It's certainly not needed. We don't need someone's rubella status. We don't need their HIV status. It certainly it comes across as not listening and not supporting the patient when we get the full set of bloods. So please don't feel like you need to do that. If someone's, questioning still, yep, sure. But it's certainly not required.
Well, and I think it's worth noting that they can also be done a bit later. So sometimes it's worth holding off, as you say, if people are unsure, that at the point that they make a decision, whether they wish to continue or not, then those things can be, the antenatal screen can be done. I certainly see that a lot also, and I agree. There's the message that it sends to the patient, and just also from a resource cost point of view. I think Yeah.
Mm.
Particularly increasingly with private pathology providers actually charging a gap to patients. It may also be that the patient themselves paying an out-of-pocket for tests that aren't required.
Yeah.
Having said that, I think you've got to have a good discussion about STI screening. I've picked up a few cases of syphilis, which seems to be increasing. So I think STI screening is really important. Obviously, there's the balance where you don't want women to feel judged, but just by, you know, offering in a very non-judgmental way that we routinely do STI screening, I think is really important. But yeah, we don't need liver function tests and EUCs and all sorts of other stuff.
But the chlamydia and the gonorrhea, at least, can be quite good, especially in terms of the medical termination. If there's someone that's not been screened in a while, blah, 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 because in terms of risk of infection, we are, you know, the cervix is dilating with the medical termination. So it's nice if we have that to be able to treat it at the same time or beforehand, depending on timing. And I think one of the other things that it might be useful to know in terms of medical termination, a lot of people come in thinking that they're just going to go home and they'll do it and it's going to be over and done with sort of in the next very short period of time, which I'm often seeing people that we do have enough information that I can do the script that day, but it's still them finding a pharmacy that's got it in stock and can dispense it to them, which Health Pathways have done a great job of finding out which pharmacies have dispensers, which is great, but the pharmacy needs to have the actual dispensing pharmacist available and they need it in stock. And then, as just described, we've got those 2 steps required. So classically, we recommend taking the first tablet at about 6 o'clock at night, which they could do that night. But nothing's going to happen the next day. It's the following day that they're going to have the bleeding and be unwell. So people need to be able to fit that into their lives. And that's where timing can be really important, because if we're getting close to that 9-week mark, then it doesn't give them as much flexibility to fit it in. If we see them around the 6-week mark, if they know that something's happening in a couple of weeks and their kids are going to be away or whatever, they're having a day off work, someone can be with them, it makes it much easier. So as getting as early as possible, but also making sure where possible that they know that there's a delay in terms of when it's actually going to happen.
I see a lot of very young women, so teenagers, who are contending with living with parents, relatives who don't know they're pregnant. Definitely, they don't want them to know that they're having an abortion. And so having a really thorough discussion with them about where they may be able to go. Is it that they have a friend's house or a partner's house that they can go to, you know, and in terms of timing, so I was talking about working backwards. Let's think, when do we want, and then working backwards to when you time the 2 medications, and working around school is a common one that I talk to people about. So I think, yeah, these are important considerations. You know, are you going to be at home? Is mum going to be at home all day? Is that going to be a problem? Do you have someone that can be with you who you can trust? And as Mel said, I do a clinic on a Friday afternoon, and that's actually quite good timing for a lot of people, because they can go straight to the chemist down the road who keeps lots of MS2 stock in step for us, and go home and take the first step, and then, you know, second step Sunday morning. And often, you know, they're sort of done on Sunday, but everybody's life is different. So that can be, and as Martina highlighted in the comparison, you also don't know exactly how long it's going to take, and sometimes the process is longer than anticipated, and that can be a bit challenging to manage.
And there's a question from someone about working in a walk-in centre. So I'm going to assume that you're a nurse in a walk-in centre, and that you generally direct clients to MSA and GCA. So, yep, feel free to offer them the option of private practice. I would say that in general, you're going to get a patient in much faster to general practice, assuming that they are happy with a medical. If they're not sure, that's where the counselling options can be quite helpful, so that it can help them make that decision about which one they want. And then if they want a medical one, yeah, if you're in and cost can be a big difference. It can be quite a lot cheaper in general practice to have it done if they're happy with a medical, and that's why some people choose a medical, because they can't afford a surgical. If you've got health pathways access, which you should have if you're in a Canberra Health Service facility, you'll be able to look us up there, or you could direct them patients to ShiftPact if they give them a call. I'm pretty sure it's just reception that actually gives them, and I'm sure someone online could correct me on that. I think it's just reception that have the list and provide it, and they do a really good job. I get quite a few people coming who have come from ShiftPact, and they generally comment about how professional and supportive and understanding they found it calling ShiftPact, which is always, you know, nice feedback. So feel free to have that as an option. So there's a question about any news on the ACT government covering costs. That's meant to happen next year. It's from July, 1st of July. I think it's probably the financial year. They are currently working on it. I believe there are discussions that have already started happening, and that hopefully we're going to have the policy people talking to us who do it in general practice shortly to start looking at how to do it. So one of the big things that they realized in government, which is why we haven't got the details about it, if it's going, like if we've got medical terminations being provided in general practice, how is that actually going to be paid for? Because obviously if we're charging Medicare, we can't get funding from any other option. So they know there's nitty gritty that needs to be worked out. And hopefully we're going to get that worked out in the next 8 months. And it will be all up and running from the 1st of July. We'll see how that goes, but hopefully we will have it. And then, I mean, it comes back to the fact that they are only covering up to 16 weeks. And obviously that 14 to 16 weeks can still be a bit questionable. And those groups of people who aren't appropriate to have it done at Murray Stopes or GCA, still where are their options? I guess there are some options at Canberra Hospital, but still that's only up to a certain period of time, and they're not offering at this point to do everyone. So we are still, as much as they're saying free for everyone, I think there will be still costs for people who need to go to Sydney, because there's no comment at this point for people beyond that stage, but hopefully we will get movement. Oh yes, good. And Claire Holberton from ShiftPact has pointed out to us that the unplanned pregnancy counselling at ShiftPact is free to the patient, that they are funded for providing that counselling. So that's not a cost for them to actually access that pregnancy, non-directive pregnancy counselling.
Yeah, I think that's a really good option, I'd say, for people who aren't sure, because as Mel said, it may be that if you're seeing someone who, you know, is aware of the options and has discussed that, they may want to go straight to a provider, but there are many people who really have no idea what's actually available or the different considerations. So
do you guys feel like we've missed anything there? Anything popped in your heads that we haven't said?
You talking to me and Martina or the audience?
No, you too.
I don't think so. I think I always wonder if people listening think, oh, they didn't say this, or what about that, or.
Well, looks like we've answered all the questions for the time being. If you have any more, please feel free to shoot them through to, if you've got any of our details, to us or to CHN, and they can pass it on to us. So Gina's asked if the ShiftPact counselling is free if non-Medicare. Yeah, I'm pretty sure that it's provided by the nurses, so there's no Medicare billing available for it anyway. So, but good question. So yes, the ShiftPact counselling is free for everyone.
I was going to reiterate to Mel and your comment, Martina, about our sort of, you know, that we've got a local sort of WhatsApp chat for prescribers for MTOP, the MTOP Down Under group. I mean, I think they're generally, as you'd hope, inclusive, supportive, educational spaces. If you were thinking that you might be interested in getting involved, but you're not at the point of feeling comfortable prescribing or just wanting to get more information. You know, I think I speak for those of us in the local group. You know, you'd be more than welcome. Noting that, you know, sometimes it's just knowing that you've got that support, not feeling out of your depth. I think that there's a lot of us, you know, who recognise that having colleagues who you can reach out to if you're not sure. And I mean, it's great. People share, you know, I've got this patient, I'm not sure. And it's great being able to quickly source that information.
And also very happy to support or sort of mentor anyone who's wanting to get into that space as well, or provide extra training as well.
Someone's asked about the training. I'm just going to add one comment about our group. It's great when we know each other. I think that's really, I get different things out of the different support groups. And I think that's really important for me at times, that I want to know who's actually giving me my answer, and I know what their level of or I have an assumption about their level of experience or level of understanding. And we did recently help a colleague with a pickup of an ectopic pregnancy, which I'm pretty sure that's what they were querying. But it's just that confidence when you run it past your brain's trust of going, yes, I should be worried about this patient. And it turned out that patient did have an ectopic pregnancy. And when the GP rang them to say, I'm worried you've got an ectopic pregnancy, I want you to go into hospital, she just started having pains. And by the time she ended up getting through ED and getting her ultrasound and getting up to theatre, it actually ruptured in theatre. So I know that GP was quite helpful, or found our group quite helpful, just to support her in the concern that she had, that it was an appropriate concern. So.
And I think with a patient that was a bit reluctant to go to hospital, I think having that support and, yes, you know, validated in her concern, was able to really strongly counsel and advocate for the patient, which I think can be hard if you're feeling, you know, less sure of yourself. Martina's beat me to the link. I was going to say it's really easy, and you can just register and do the training. It's very straightforward. I use the MS Health resources with patients, and you can, I think there's others who are attending tonight who did the training sometime but didn't necessarily start prescribing straight away. Like, that's the other thing, is that you can do the training and it doesn't obligate you to start prescribing, so you can get that more information and actually, you know, then decide whether you're happy to take that on. And yeah, as Martina said, very happy to support people who are wanting to start doing some of this work but feel like they could use some extra support.
Okay. Well, thanks, Jess and Martina. Appreciate you guys. Oh, hang on. We have more questions. Okay. So for an MTOP before an ultrasound is going to show us. So yeah, I guess that's the other thing, timing of an ultrasound. So getting an ultrasound at 4 weeks and 5 days is not going to be helpful. We're not going to be able to prove it's intrauterine, which is the whole point of having the ultrasound. So if you think someone's still too early, if they're before 6 weeks, there's 2 options. One is they wait until they're closer to 6 weeks and get the ultrasound. But if we have a beta HCG of, is it less than 1,500? No, less than 5,000.
So you should see an intrauterine pregnancy with a transvaginal ultrasound at a beta HCG of 1,200 and a transabdominal at 1,500. Now, currently, there is a study, an international study happening, in Sexual Health and Family Planning New South Wales, a part of this study, looking at medical termination of pregnancy prior to 5 weeks, prior to ultrasound confirmation of intrauterine pregnancy. I think at this stage, the medico-legal sort of basis in Australia is that you do need an ultrasound with a yolk sac present. So you need a gestational sac, a yolk sac. You don't need a crown rump length as long as you have a yolk sac. I suspect that in the coming 12 months that the study results will come out, and there may be a change of protocol. So it's a little bit of a watch this space with an ultrasound, you know, with a pregnancy that is not yet confirmed on ultrasound.
Yeah, I think we've discussed this, I guess, amongst ourselves, that it would be fantastic, and you recognise, it's easy to recognise the benefits of the earlier in the pregnancy, not asking people to wait to get an ultrasound. But as Martina said, it's a bit of a tricky area where I think any of us prescribing earlier without an ultrasound would be going outside what is current accepted standard clinical practice. So hopefully that will shift with more evidence.
Yeah, the actual PBS item when you do the authority script is that you have to state that you have a confirmed intrauterine pregnancy, and without an ultrasound you can't do that. So currently the PBS rules state that you essentially must have an ultrasound confirming an intrauterine pregnancy. And yet, sorry, the second part of Tracy's question was just about the anti-D. So no anti-D for MTOPs at less than 9 weeks. And also we'll add no anti-D for miscarriages at less than 9 weeks. Same thing, they've changed the guidelines, which is much easier for GPs to then manage in the community, because you don't need to get anti-D, which is always a bit of a pain.
It is much easier. When I started doing this in private general practice, organising anti-D, you can do it, but of course, if you're not using it very often, it's a pain. So it is great not having to worry about that step.
Yeah. So there's just a question. So Mary Stopes in Canberra. So there's 2 places. So Mary Stopes in Canberra, you can get a surgical termination of pregnancy, and GCA, so Gynecology Clinics Australia, which is just in Queanbeyan. So it's actually very easy for patients to get to. So anaesthetics, so we have GP anaesthetists and consultant anaesthetists who come and do the sedations for us. We don't offer general anaesthetic. So in terms of anaesthetic, we either do a stop under local, which is a cervical block with usually fentanyl and midazolam as analgesia, or we do a sedation with propofol, fentanyl and midazolam. I hope, does that answer your question, Annie? Okay, so anti-D greater than 9 weeks. So we know that at greater than 9 weeks, you start to get fetal maternal mix of blood. So that's why you do NIPT testing at 9 weeks and above. So above 9 weeks, you can detect fetal DNA within maternal blood. So we know that there's mixing of blood, so potential for rhesus isoimmunization at greater than 9 weeks. At less than 9 weeks, there's minimal or no mixing of blood, so no risk of isoimmunization at less than 9 weeks. I hope that answers that question there.
I think that's a great answer.
I was going to say and that's regardless of whether it's a twin pregnancy, because it's about the timing of when there's mixing. Yeah,
it's about the placental function. Yeah.
Yeah.
And look, I think probably really in the end, they'll get rid of anti-D at less than 9 weeks for surgical. But there's kind of like a theoretical risk that because you're disrupting the placental circulation in a different way, that you could have mixing. But again, it actually doesn't make any sense if you think about the physiology and the anatomy. So I think eventually that will go, but it's not quite there yet.
Okay, excellent. I think we've well covered our time, and we can all go off and enjoy the rest of our night now. Hang on, I think there's stuff I meant to do. Yes, thank you to CHN again. Thanks, Jess and Martina. There's possibly going to be an evaluation survey that's going to pop up after this is concluded. Certificates will be sent out shortly. I don't know whether you're getting certificates because we've not done the RACGP thing.
You can have a big thumbs up. So thank you for coming along. There's your verbal certificate.
And I think that our slides will be available afterwards as well. I'm certainly happy for mine to be, and I'm guessing you guys are too.
Yeah. No problem.
And thank you, and we will see you all soon. Thanks. Bye.
Good night, everyone.